Okay, so I figured I would start this talk by introducing myself first. So like I mentioned, my name is Dr. Julia Fisher. I'm a board certified dermatologist. I practice medical, cosmetic, and surgical dermatology. And what that means is that I treat everything dermatology related, acne, rosacea, rashes, and also cosmetic dermatology, Botox, laser fillers, and surgical body contouring as well. In addition to that, I'm a fellowship trained Mohs surgeon, which means that I specialize also in the diagnosis and treatment of skin cancers, specifically in the Mohs micrographic surgery technique. Apart from my private practice, I'm also a clinical instructor at the VA Medical Center where I teach residents once a week, and I'm on voluntary faculty at Mount Sinai Hospital as well. So that's just a little bit about myself and why I'm so passionate about skin cancer. So let's get started. So what are the numbers? Why are we even talking about this? Dermatologists diagnose over 9,500 cases of skin cancer every day. That's a huge number. And last time the counts were performed, or the studies were performed in 2012, over 5.4 million cases of non-melanoma skin cancer were treated in that 1 year of 2012. That's a lot of skin cancer. And most people, by the time they're age 70, 1 in 5 Americans will be diagnosed with skin cancer. So it is an important topic. It's a very large number of people that will be experiencing this, either personally or family and friends. So it's good to be informed, and it's good to know, what the expectations are. So the good news about it is that the majority of skin cancer is entirely curable when it's caught early, even melanoma. So that's another reason why it's important to know about skin cancer, because the earlier you catch it, the more likely it is, what I like to tell my patients, more of a nuisance than something that will be life-threatening. So non-melanoma skin cancer, what are they? Basal cell skin cancer, squamous cell skin cancers are non-melanoma skin cancers. Actinic keratoses are more of like a precancerous lesion. We'll go into each of these in detail. And I apologize for the gruesome pictures, but these are what skin cancers look like, and I'll show you a couple more pictures as well. So actinic keratoses, not actually skin cancer, but a large majority of what we treat in office when we're doing our skin checks are these actinic keratoses. They are precursor lesions to squamous cell skin cancer. In a large study that was performed, they found that 1% per lesion per year can go on to become these squamous cell skin cancers. So and the reason why we treat them all, though, is because we don't know which one will. And if a patient has a large burden of these precancer cells on their skin, there's a good chance that these will go on to become these squamous cell skin cancers, and our goal is to try to prevent that. So if you can see on the right here, they're kind of like these like red, kind of scaly or gritty bumps, and patients usually have them anywhere on their body, but typically it's on the arms, on the scalp, on the face, on the backs of the hands. Those are the very common areas where we see them. And typically, dermatologists, and myself included, will treat them with something called liquid nitrogen. You can see the little canister over there on the left. It's like a cold spray. We often use it also for warts in children. And that's to see if we can destroy those cells so that they don't go on to become these squamous cell skin cancers. I love actinic keratoses because I feel like I'm actively doing something to treat or prevent patients from getting skin cancer in the future. So field therapy is a big part of our practice. Field therapy is basically when we treat the whole area, what we see in terms of these gritty spots, but also what we cannot see in terms of the sun damage that's under the skin, the DNA damage that's already been done, but it has not manifested in the skin just yet. So field therapy is fabulous, and we have topical chemotherapies that we can apply, topical immunomodulator therapies that we can give patients, and also blue and red light photodynamic therapy. We can do chemical peels. We can use CO2 laser, which is also FDA approved for the treatment of AKs. So, you know, we have a lot of options. It's great. And basically we just pick what would be best for our patients at that time on that day. So that's actinic keratoses. Basal cell skin cancer, the most common type of skin cancer that we treat. Usually I tell patients what they need to be looking for is a pimple that doesn't go away, a spot that bleeds, a spot that hurts. So they can sometimes be scaly pink, they can be shiny pink, you can see in the pictures here. They can even be pigmented, they can be brown, and they can sometimes even look like melanomas, which can be scary for some patients. But they are relatively, they have a relatively benign course in the sense that if you catch them and we treat them, they're never a problem. You know, it's very, 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 very rare that basal cell skin cancer ever goes on to spread to other parts of the body. And, you know, they unfortunately never stop growing. And that's the main reason why we treat them, because they can be locally destructive, which is the word that we usually use. But at the end of the day, as long as we remove them, most patients do completely fine. So those are basal cell skin cancers. Just be aware of these like pink spots that you never really had before, and they're not going away. Like, why is this new pink bump here, and now it's bleeding, or now it's starting to be a little uncomfortable? That's what most basal cell skin cancers look like. So squamous cell skin cancer, I alluded to this earlier. It's another type of skin cancer. This one arises from the skin cell itself. These are usually scaly, painful bumps. They sometimes don't have to be painful. They can be either, you know, nodules, as you can see here. They can be kind of thin, scaly plaques, like the earlier lesions can be these kind of thin, pink, scaly plaques. One of the subtypes of squamous cell skin cancer is something called a keratoacanthoma that you can see on the bottom left here. And these are usually characterized by rapid growth, and patients say, you know, it started as something that looked like a pimple, and now it's like 3 to 4 or 5 weeks later, and it's this like big bump. I never had anything like this before, and that's an keratoacanthoma. And these, again, they have a little bit more of a potential to spread compared to the basal cell skin cancers, but if you catch them early and we take care of them, they're usually also not a problem, as long as we don't let them kind of go unattended. If we don't ignore them, most patients do just fine. And then, you know, the big scary word, the melanomas. You know, melanomas come in many different colors, you can see, many different shapes. They can occur almost anywhere on the body, including on the nails and on the toenails. That's actually, some of you may be familiar with, that's how Bob Marley died. You know, he thought that he had a soccer injury on his toe, which actually turned out to be a melanoma. They can also occur in the eyes. So it's another reason to make sure you get your annual eye checkups. But, you know, these lesions are, you know, we know what we're looking for, and I'm going to also let you know what you should be looking for in terms of what spots to bring to our attention if there's something that you might be concerned about. So usually melanomas, what we look for is something called the ABCDEs. So something that's asymmetrical, where the two sides of the lesion don't necessarily match. So it's not something that is like a mirror image of itself. If the borders are uneven, so you can see in the picture on the right, there's kind of this jagged looking edge instead of a nice smooth edge. If the lesion has 2 or more colors, or if the colors are very distinct, or has a very dark color in some areas, I want to see it. If it's the diameter is larger than basically the circumference of like a pencil eraser, so larger than 1/4 of an inch, we also want to see that spot. Anything that's kind of on the bigger side, we want to make sure that we evaluate. And evolving, anything that's changing. This is one of the biggest indicators for me. If someone says this is new, this is changing, I think the color's getting darker, even if it looks potentially almost completely normal, if you're telling me it's changing, that to me is a red flag, and that's something that I would want to check. Other things that we look out for, the ugly duckling sign. So the ugly duckling sign is a mole or a bump that looks different than the rest of them. So sometimes patients have what I call signature nevi. So many moles, and all of them look a little bit unusual, but they all look the same unusual. And that's an important indicator. We don't want to go, you know, if somebody has like 10, 20, 30 spots, we don't want to go chasing every single one of these spots if they all look the same. But if one of these spots looks different than the rest of them, one of these moles looks darker or lighter or just a little bit more unusual than the rest of them, that's the one that we want to look out for. And in addition, if there are no spots anywhere and someone has, you know, significant sun damage, for example, and they have one brown spot on their cheek that might be new or changing, that to me is also a red flag. That's an ugly duckling sign. So, you know, dermoscopy, I use dermoscopy all day. I feel like it's an extension of my hand. So what is a dermatoscope and why do dermatologists use it? This is a special device that helps us see through the top layer of the skin. And you can see an image on the right here that this is a melanoma. It helps us to see more features, and it helps us to distinguish these more benign spots with melanoma spots. So we're a little bit more accurate with our skin exams. And just as an aside, there are other devices that are being researched, that are being investigated now for introduction to our clinics, like reflectance confocal microscopy or optical coherence tomography. There are other ones, and I actually use a lot of these devices at the VA when I'm teaching residents, and a lot of our research at the VA is with these devices. And they're, you know, eventually we might start seeing these popping up in our clinics, and they're just going to be more ways for us to be able to make, I guess, better decisions on what needs to be biopsied, what doesn't need to be biopsied in patients going forward, because they can give us more information about these spots before we even take any biopsies or any pathology. And then there's also a lot of benign lesions that look funny. You know, all the spots on the slide are all benign lesions. Some of them just moles that look a little bit unusual. Like the top row are all normal moles. The bottom row are, the bottom left is just a specific type of lentigine. And some of these are other kind of like benign growths. The one on the bottom right is something called a keratosis or a seborrheic keratosis. We see these all the time. These tend to be very obvious to patients, and these are the ones that usually bring you into the clinic to show us, but these are completely fine. They never become anything. But this is really just to highlight the fact that, you know, just because something does look funny doesn't mean it necessarily is something to be worried about, but that's why we're here. So you can come in, you can show us these spots, and then we can either reassure you or let you know that it's something that we should sample. So what can you do? Why do we talk about skin cancer if we want to be able to give you the tools that you need to hopefully prevent these in the future? So we know that ultraviolet radiation or radiation from the sun is a known human carcinogen. We know that. So, you know, this is what we target when we tell you to tell you what you need to do in order to hopefully prevent skin cancers in the future. It's a well-known risk factor that UV radiation causes melanoma and non-melanoma skin cancer. It is also the main cause for wrinkles and photo damage. So sometimes my patients tell me, oh, but it's so hard to wear sunscreen, but I tell them, yes, skin cancer is something that you don't want to think about, but wrinkles will hurt. So you use your wrinkles as a reason to wear your sunscreen every day. Another point that's important to know is that UV radiation is immunosuppressive. And we actually harness that in our more therapeutic UV light for like inflammatory conditions like psoriasis, vitiligo. We actually give this as a therapy. But in the context of skin cancer, UV radiation being immunosuppressive actually drives the formation of these skin cancers. So another reason why it's important to always continue to be diligent in the sun, because yes, the bottom of the slide here, exposure in childhood is extremely important, and having significant exposure in childhood does increase your risk of all skin cancers going forward. So the large proportion of what's going to decide your risk for developing skin cancer going forward is going to be the sun exposure that you had in, before the age of 18. But going forward, you also want to be able to mitigate any additional damage that you're going to do, and also not immunosuppress your skin to the point where it actually starts to miss these abnormal cells, and then they become skin cancers. And I'll go into that in a little bit as well, a little later. And then the other thing I just want to draw attention to on the top right is the different types of UV radiation that actually comes from the sun. So, there's 3 different types. The numbers here are actually kind of like arbitrarily assigned in terms of like what UVA, B, and C is. UVC is largely filtered out by the atmosphere, so it doesn't really reach us. So it's not really important in terms of discussion for skin. UVA goes deeper into the skin, and it actually reaches the dermis, and that's usually the one that we attribute to aging and photo damage, because it does get into where our collagen and elastin lives, and that's the main driver of this like photo aging. And UVB is not as deep, but UVB also has been more associated with like sunburns and redness that you get after the sun, and both of these are have actually been thought to contribute to the development of skin cancers. So what happens when you tan? UV radiation comes to your skin, and it basically bombards the skin within seconds of you going out into the sun. And your melanocytes notice this, and they basically wake up and release all of the melanin, all of the pigment, the brown pigment that they make inside, to the surrounding cells, hopefully to protect them from some of this damage, so like these little umbrellas over your DNA. In addition, what the melanocytes do is they say, wow, I've gotten rid of all of my melanin. What else can I do to try to protect myself from this damage that's coming? So they increase replication of melanocytes and also increase the production of melanin. And some of the other cells also start to increase their replication. So your keratinocytes will also increase the replication. That's what that kind of like thickening or kind of like leathery skin appearance that patients can get after significant sun damage is that thickening of the epidermis, also caused by sun exposure. So any tan is a sign of sun damage. So when patients come in and they tell me, I wear my sunscreen, but I see that that they're deeply tan, that if you've gotten a tan, that means your sunscreen has failed. Any tan is a sign of sun damage. So that's important to keep in mind. And over time, like I mentioned previously, is that the UV radiation can also break down the collagen and elastin, and that will lead to wrinkles, saggy skin, and also sunspots. So, once you spend a significant amount of time in the sun, you can get redness, burning, you can even get blistering sunburns, and then your body has to repair that. So, when that repair is happening, if the cells miss things while they're repairing, it's possible that they make these little mistakes. And these little mistakes happen all the time. And most of the time, these little mistakes either get fixed, or the cell makes too many mistakes and basically your body kills it off, or the immune system finds these cells that make little mistakes and it gets rid of them. Or sometimes they're kind of just silent mistakes, and they don't make any difference in your skin or in your body at all. However, when there are a significant number of these mistakes and they start to build up, and also because the UV radiation can suppress your immune system, some of these mutations can become more what's the word I'm looking for? They can become sustained. And this is what causes skin cancer. So a mutation in a melanocyte that then in for example, an oncogene or in a gene that can go on to cause this replication that we see in skin cancer, that becomes melanoma. Similarly, a mutation in a keratinocyte goes on to become a squamous cell skin cancer. So, many things have to happen. All these things have to line up in order to make skin cancer, but all these things taken together, it does happen, obviously. And that's why you see this in later stages of life, because, it's been that many years of collecting sun damage that has finally kind of turned this skin cell over, and now it's become a cancer. So, what can you do about this? So, sunscreen is the mainstay of treatment, or in terms of prevention. So this is a graphic that I actually took from the American Academy. I think it goes over sunscreen really well here. So, we have two types of different sunscreens. We have physical blockers, we have chemical blockers. Physical blockers are the mineral sunscreens, the ones that work like a shield against the sun. And what you're looking for is titanium dioxide or zinc oxide. And, these are the ones that are kind of like those heavier white looking sunscreens. There are more elegant formulations, these micronized formulations. I really like the Isden sunscreen that we actually carry in office, because it has, again, this mineral component, but also is pretty elegant and has other kind of like photoenzymes, I guess you can say, that help to decrease sun damage, actinic damage in skin as well. So those are the physical sunscreens. So physical sunscreens work as long as they are on the skin. So if you sweat them off, if you go swimming, they're no longer working. So you have to reapply every 2 hours if you're outside, and it has to be a significant amount. You can't just put a thin little layer on, because that's not going to work. And you want your sunscreen to be at least an SPF 30 or greater. Chemical sunscreens work a little bit differently. They work to absorb the sun's rays. And they're a little bit easier to spread. Patients like them because they're usually available in, like the sprays and the gels and lots of different formulations. But the caveat with them is you have to put them on before going out into the sun, because they take a little bit of time to work. And you also have to reapply them often. Patients can be allergic to them, so that's another thing that you have to be a little bit more mindful of. So they are more commonly to cause irritation in the skin. And now, obviously, also there's been some data going over the fact that they may be absorbed into the skin, but what does that actually mean to us? We don't really know what that actually means. But usually I tell patients, if you're concerned about that, just go with a physical sunscreen. We know they work. They have a good track record. You just reapply them, and they're safe. So what are the other things that you can do? Prevention. Sun protective clothing. Sun protective clothing now has become kind of like a much more accepted thing to be doing at the beach, or even out when you're out. And there's companies like JUVASkin. You can see this woman doesn't look like she's wearing sun protective clothing. She looks like she's just going out for a jog, and this is sun protective clothing. I think I just took this off of one of those websites. You want to get a wide brim hat, a hat that will protect both your face, but also your ears and the back of your neck. So I think there are many options for these as well, that are easy to find, and they can be stylish too. Other things that I tell patients to consider, especially if you know that you're going out for a long day. Once the weather starts getting nicer, people will be golfing, hiking, boating. So what are the other things that you can do to protect your skin in addition to your sunscreen? Antioxidants like HelioCare have been shown in studies to help decrease the risk of burns. They do not replace, HelioCare cannot replace your sunscreen, but it can help. So it's kind of like a booster. So I tell patients, if you know you're going to be out for the whole day, if you know you're someone who is not very careful with your sunscreen, but you're doing your best, HelioCare might be something that you can consider adding. Don't forget to wear sunscreen in the winter. Don't forget to wear sunscreen when you're skiing. You can see the photo of this woman on the right. This is a very famous photo from the New England Journal. She is someone who spent like 20 something plus years. I believe she was like a truck driver in her car. The car does not filter out. The car window does not filter out UVA. So you can see there's significant sun damage on the left side of her face. And this is why you should wear your sunscreen even when all you're doing is going from home to work in the car, or just going in the car for, you know, whatever period of time. It's important because you're not protected. Obviously avoid tanning beds, and another important, probably one of the most important parts of this is see your dermatologist for a skin check at least once a year. Sooner, obviously, if you notice something that you might be worried about. So, you know, what to expect when you come in for a skin check with us. Obviously, you'll be asked to change into a gown. And as dermatologists, we treat everything, hair, skin, and nails. So we examine everything that you are comfortable with us examining. So we start from the top, and we really don't miss any spots unless there's something that you tell us that you don't want us to look at. Obviously, we will address any concerns that you may have. If there's something in particular that, for me at least, that's the first thing that I look at, because I want to make sure that we check whatever it is that you might be worried about. But then I also look for things that you may not have noticed. And then, you know, what happens if something doesn't look completely normal? You get something called a skin biopsy. This is not something that should be alarming to patients. It's a very simple procedure. We do many of them every single day. They're usually very comfortable. We put a tiny bit of numbing medicine in. We remove a small area of the skin and we send it to the lab. And this tiny wound takes some time to heal. If it's something that needs to be addressed, we will go over what, you know, our recommended treatment for it is. And obviously, you know, if hopefully it's nothing, and then you just let the little spot heal over, and then you're usually left over with a tiny, tiny mark that becomes almost invisible over time. And, you know, so then the skin self-exam, you know, this is really the recommendation from the American Academy of Dermatology. It's not a very easy thing to look at your back and, you know, your shoulders, the back of your neck. Obviously, it's much easier to do this if you have a partner that can help you, but you have to do your absolute best to keep track of your spots. And obviously, if you notice any changes, come in to see us and we can address those for you. So treatment. How do we treat skin cancer? So like I mentioned earlier, I'm a Mohs surgeon. Most non-melanoma skin cancers are treated with Mohs micrographic surgery, especially on the head and neck, on the hands, on the feet, in areas where where taking more normal skin for the skin cancer treatment will be basically not favorable. So how this works, you come in, basically plan to spend the whole day with me. We numb the area. I remove what I think is tumor and I look at it under the microscope. If the tumor is completely gone, then you go to the last picture here, we get some stitches and you're done. If there's anything left, I go back and I only take what's absolutely necessary. I only take the little bit that you see on the bottom there that looks like that's where the skin cancer was, because I use a map in order to keep track of where it is on the margins. And then we repeat that process over and over again, hopefully usually only 1 or 2 times, and we're all done. Then we do some stitches, and the stitches can be something like you're looking at here, which is a flap. Sometimes it's just a straight line. Sometimes we have to borrow skin from other parts of the body in order to fix things. And sometimes if it's an area that is either particularly tight or will cosmetically heal well, we can let it heal on its own. So that's one way to treat these skin cancers. Other treatments that are available are surgical excision, something called electrodesiccation and keratoses, which is basically just scraping and burning the spot. We have other ways that we can treat things with topical and even intralesional chemotherapy. Less favorable treatments, at least especially for our younger patients or patients that have small skin cancers, or radiation. So that's really more of like a last resort. And, there's other, obviously, referral for like oncologists and other chemotherapies, something that most of the time we don't have to discuss, thankfully. And then there's also, coming down the line, laser treatments for some of these skin cancers. There have been recent publications of good success for particular types of skin cancers. I don't think it's ready for prime time just yet, but it is something that might be coming along soon. And with that, this is, I believe, my last slide. So what does coronavirus, what does COVID mean for our skin cancer patients, and what what should we be doing in terms of skin cancer? So the recommendations from our, like, from the Mohs College is that we do have a little bit of wiggle room. So we can defer many of these skin cancers for the next 2 to 3 months if it's absolutely necessary, because a patient being high risk for COVID, or not really wanting to come to the office for treatments, or we think that the risk of having the patient travel for the treatment of this outweighs the risk of potentially the skin cancer growing. So if necessary, we can defer these, and we can defer them for the next couple months, hopefully when things start to kind of quiet down. So the ACMS the American College of Mohs Surgery, has released a statement saying that the NCCN, which is another kind of governing body for cancer, has even made a statement that we can even defer some melanomas for a couple of months if it's absolutely necessary, obviously at the judgment of your physician. So if this happens, don't panic. We will talk you through it, and we will make sure that we do what's right for you and the treatment of your skin cancer. So that being said, if you have any questions, if you need an evaluation with one of us, the office is open for limited visits, for limited in-person visits, and we are also offering virtual video consults and appointments over basically over a similar platform as this, but we can see you almost any day of the week through virtual video consults as well in the meantime. And follow us on social media, and thank you for your attention. And I can take some questions if anybody has any questions. Let's see. I see a question or a raised hand.
Yes,
Okay.
I have a question. My question is about the red light therapy. I wasn't sure if you're referring to like the laser-based ones, or are you actually talking about some of the ones that you can buy for home? I think there's one made by a company called JUVA. I don't own it, but I've seen it advertised. And I was wondering, it seems like a new field, and I really don't understand what devices are considered therapy and which are not, and whether the ones you can get at home do anything good for anybody at all.
Okay, that's a great question. So the red and the blue light therapies that I'm mentioning are something called photodynamic therapy. So they're actually used in combination with a medication that has to be applied in office. So it's not something that you can do at home. Usually we plan to do this together, and we plan for you to come in so that we obviously have this medication on hand. Basically what the medication is something called levulonic acid. It's a type of medicine that gets absorbed into your into the rapidly dividing cells in the skin, which are these precancer cells. And it gets converted into something called protoporphyrin 9, which is basically just, it uses some of the cell's machinery basically to convert into this. And the light then is applied to the skin in order to activate this protoporphyrin, which then creates reactive oxygen species, which are kind of how do I explain this? It's kind of like basically what you're trying to get rid of when you take antioxidants, if that makes sense. But basically it turns on the cell's machinery in order to kill off these cells, in order to kill off these rapidly dividing cells and these cells that have these reactive oxygen species in them. So that's how we get rid of these precancers with that red light and the blue light therapy. So it's not something that you can do at home. I think that's a great question. And now we're seeing a lot of these red light treatments, and even some of them for like anti-aging, and they're being studied even for wound healing now. I think that some of these devices, that they're probably being marketed more for anti-aging and they wouldn't work without this medicine for precancer. Okay, do we have any other questions? How do
I have one other question, if it's okay. And that is, as we know, lack of sun is one of the reasons why most people have a low vitamin D in their blood. And, you know, is there a balance between sun for vitamin D, which has its own risk factors, and obviously too much sun? Or would you just say, you know, forget the sun exposure and just get a vitamin D3 vitamin pill?
So, I mean, that's a great question. I think that many dermatologists actually don't know how to answer that question because there's not enough data. So, if you check most people, if you check most healthy patients' vitamin D levels, many of them will be vitamin D deficient. And, you know, it's easy to just supplement your vitamin D with just a vitamin. And I mean, that personally, I think that's what I would prefer. For myself, because I understand like the risks of the sun and prolonged sun exposure. So, you know, some patients say, you know, I get 10 minutes of sunlight, you know, early in the morning or something, and you know, I think it's acceptable. At the end of the day, there has to be, you can't be so black and white. We can't be so super strict with absolutely everything. But I think that, you know, extensive sun exposure, if you're going to get those 10 minutes of sun during peak sun hours, like noon at the beach, I think that's a bad idea. But if you're someone who likes to take, you know, like a 10-minute walk in the morning at, you know, before it's very peak time, you know, so like at 8 a.m., I don't think that's the end of the world. Unless you're someone who has, you know, a very significant risk of melanoma or a history of, you know, multiple melanomas in the past or many skin cancers in the past, then I would say, you know, I think it's a better idea for you not to do that. But, you know, we do, like I mentioned earlier, use UVB in a therapeutic range for inflammatory conditions, and you know, many of these patients do well. Do some of them develop skin cancer? Yes, of course, and especially with our prior therapies like Sorlin and UVA, those patients do end up, you know, we see those patients now with many skin cancers going forward. But you know, so there is an amount of UV that is probably okay in the long run, but you never know when your tipping point is going to be. So you do want to balance that. And I personally think that if you're worried about vitamin D specifically, that's the reason why you want to go out into the sun, I would just take a supplement. Okay, so I think that's probably it if there are no other questions. And thank you everyone for joining us. And oh, I think I have one more. Hold on. Oh no. Okay. Okay. Yeah. So thank you everyone for joining us. Obviously, we're here if anybody has any questions. You can, you know, feel free to reach out to the office, and we're happy to schedule, you know, a video appointment if necessary. And hopefully, we will see you all on the other side of this coronavirus pandemic. Okay, so stay safe, everybody.